Hi, everybody, and welcome to a Prasiska GI Cancer-Focused Tumor Board. My name is Sam Klepner. I'm a GI medical oncologist at Massachusetts General Hospital in Boston, and I'll go around as I see it on my screen. So I'll start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Hi, everyone. I'm Pritesh Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University in Atlanta.
Hi, I'm Marty Weiser. I'm a colorectal surgical oncologist at Memorial Sloan Kettering Cancer Center in New York.
Hi, I'm Al Benson, and I'm a GI medical oncologist at Northwestern University in Chicago.
It's a very young woman with a history of a stage 2 neuroendocrine tumor of the appendix that was resected with no evidence of disease on post-operative imaging. And the topic of discussion is additional treatment and imaging, if any. So the history is that this is a young woman presented with a history of right-sided stabbing abdominal pain with a performance status of 0. CT abdomen and pelvis initially. We'll have a couple images, but particularly commenting on the appendiceal findings. Patient underwent a surgery which revealed a 1 centimeter low-grade, grade 1 neuroendocrine tumor of the appendix invading the serosa and mesoappendix. There was a positive perineural invasion without lymphovascular invasion. The margins were negative. This was staged as a PT3 tumor, and post-operative CT scans had no evidence of disease. So I will show you the available imaging, and here is a view that we have. Dr. Siegel, feel free to comment.
So this is a coronal CT, and you can see there's an arrow pointing to just a mildly enlarged fluid-filled appendix on this view. And if you'll go forward to the next one, and then here, farther down the appendix, it's not as much fluid filled, but it's a little bit has a little bit more of a thickened wall. And then on the final view, you'll see it's not only thickened, but it's sort of asymmetrically thickened. The medial wall is thicker than the lateral wall. So honestly, I think most radiologists would just read this as a kind of a subtle case of appendicitis. I don't think people would be including a neuroendocrine tumor. I think this would be read as kind of a low-grade case of appendicitis. I don't think there's really any signs of any complication. There's no fat stranding around the appendix. There's no fluid around the appendix. There's no appendicolith. There's no evidence of a complicated appendicitis like a rupture. I think this would be read as just sort of a subtle case of appendicitis. I think in this case we would be wrong, but I think that's what radiology would say.
Yeah, I think similar to our incidental gallbladder cancer, again, not an uncommon clinical scenario. So I'll start with Dr. Weiser. I know this is getting into your particular area of expertise down in the colon. Let's say that one, is there a role for additional surgery, right hemicolectomy, et cetera, for a patient like this? And let's say this is a higher grade tumor, and how do you think through patients who do benefit from additional oncologic surgery?
Yeah, thank you. It's a very interesting case, and there's a lot to think about. And the fact that she's 22 shouldn't be lost upon us. Recently graduated college or something like that with a whole life ahead of herself. We want to think really hard before we label her as a cancer patient that needs a lot of surveillance. In any case, these well-differentiated neuroendocrine tumors, grade 1 and 2, what we would call carcinoids in the past, a very favorable outcome. The most important factor here has always been size. And I think we probably all remember the old Mayo study saying that anyone with a carcinoid less than a couple centimeters never recurred. But we do look at some other factors. So in general, these tumors that are greater than 2 centimeters get right hemicolectomy because there is a risk of local regional lymph node metastases along the ileocolic pedicle. If it's less than a centimeter, that risk is extremely low. and patients are receive no additional treatment or surveillance, actually. If it's between 1 and 2 centimeters, that is a gray zone, and we look at other factors, such as mesoappendiceal invasion, lymphovascular invasion, and of course, positive margin. Perineural invasion is very common for these tumors and does not have the same weight as lymphovascular invasion. In this case, I would want to know a little bit more about the pathology. We would present this at a multidisciplinary conference where we would look at the pathology. I'd want to see how much of the mesoappendix was invaded, and if it wasn't, say, more than 3-4 millimeters, I would discharge her and say no additional follow-up is needed. You're not a cancer patient. However, if, say, this were a little bit larger between that 1 and 2 and there was mesoappendiceal invasion or lymphovascular invasion, I would offer right hemicolectomy.
Yeah, no, thank you for that excellent overview. I'll ask, just because we can and we have the technology, and anyone feel free to weigh in, does anyone get, say, dotatate PET scans in these patients? Is there any role for serotonin receptor-based imaging for a patient like this? Only because it comes up a lot.
I can say that
I think you might have gone on mute, sorry.
Sorry, I totally agree with what Dr. Weiser reviewed here. We would not routinely get for example, gallium-68 dotatate PET-CT because the risk of metastatic disease is so low. And we would have exactly the same discussion as outlined by Dr. Weiser at our multidisciplinary conference.
We would,
yeah, sorry, go ahead.
Yeah, we would also not get a dotatate in this setting. Although we may have asked multiple times.
We're all on the same page here. Consensus of really no additional surveillance imaging is really the evidence-based approach.